implementation, and that is Dr. Mohamed Fawzi. He's a radiology advisor to the Ministry of Health. He's a head of diagnostic and intervention radiology, I should say, from Egypt. On national, and he also is the head of radiology department at National Hepatology and Tropical Research Institute. Mohamed, those are big words, but what it is about you make things happen. His impact already on the healthcare and diagnostic in Egypt has been absolutely fantastic, and we are very much looking forward to your presentation. Dr. Fawzi.
Good morning, everyone. It's a really big honor to be here. Of course, Professor Hedi, gave us this chance and a great honor to be invited by the AMSTRO to present here. Strategizing the connection between imaging and radiation therapy, opportunities and rationale for implementing the resolution which Professor Hedi just discussed and talked about, approach to implementation in illustrating the steps to be taken. Imaging availability is directly associated with early stage at diagnosis, optimized treatment selection, more accurate staging, improved survival and quality of life. Cancer treatment pathway is from screening and early detection to diagnosis and staging, therapy decision and planning, and then follow-up. And all these use diagnostics and therapeutic machines, as you can all see. No precision oncology without precision imaging. So imaging access equals treatment access. So we want to make it very understandable that diagnostics and therapeutics work together. So we have to start by the imaging, and without the proper imaging, you will never be able to do proper treatment. The connection between imaging and radiation therapy is diagnostic radiology, where there is eligibility, staging, and intent. Nuclear medicine, functional imaging, staging, response assessment, and theranostics. Intervention radiology, where minimal invasive oncology therapies are done, biopsies, palliative intervention, and image guiding radiotherapy, which is the main core we're in now, which is treatment planning, target delineation, adapted radiotherapy. Implications for national cancer control. Imaging must move from supportive services to a strategic system investment. Alignment required between cancer plans, diagnostic lists, and reimbursement mechanisms. What are the opportunities and rationale for implementation of the resolution that was presented WHA 78.3, which is strengthening medical imaging capacity, where the resolution as a system level enabler, the resolution recognizes imaging as a diagnostic tool, a therapeutic enabler, a health system strengthening intervention. Explicit linkage to cancer detection, surgery, radiotherapy, and chemotherapy. And alignment with global priorities like the universal health coverage, and NCD control, and SDG 3, WHO diagnostics, and cancer initiatives. Why the implementation is urgent? Cancer incidence is rising fastest in the developing countries and all the AMSTRO region. And late-stage diagnosis drives which higher treatment causes meets higher treatment costs, poorer survival, and increased health system strains. Persistent inequities in developing countries and the AMSTRO reason. Uneven distribution of CT, MRI, PET CTs, and PET and radiotherapy-linked imaging, urban and rural disparities compounded by workforce shortage, limited integration of imaging into international cancer pathways, and universal health coverage benefit packages. What is the strategic approach to implementation of the resolution? From our perspective, number one is governance and policy integration, embedded imaging explicitly within national cancer control plans, radiotherapy and oncology strategies, universal health coverage benefit packages. Establish interministerial coordination, health, finance, digital transform, higher education, because without the coordination of all these ministries, each will be working on a separate island. And this is really, from my perspective, the biggest gap and problem that we have. Assign clear national leadership for imaging governance. Number 2, infrastructure and service planning. Plan imaging and radiotherapy as integrated networks, not stand-alone centers. And this is also a big gap that we are facing. And you have to prioritize geographic equity, referral pathways linking diagnostics to treatment, balance fixed, mobile, and regional hub models. Number 3, which is digital connectivity and system integration. We have to link imaging platforms with oncology information system, radiotherapy planning systems, national cancer registries, use teleradiology support to extend expertise. Workforce capacity and skills alignment. We have to train imaging and radiotherapy professionals together where workflow intersect, expand competencies in imaging for radiotherapy planning, nuclear medicine, and radiotherapy collaboration. Also, AI-supported contouring and decision support. Safety, regulation, and quality assurance, which is number 5. Harmonize radiation safety frameworks across imaging and radiotherapy. Implement dose optimization, equipment accreditation, clinical audit, and quality indicators. Strengthen patient safety governance to reinforce trust, which is really needed. Steps to be taken from policy to practice. Sorry. Step number 1, which is the national assessment, map current imaging and radiotherapy capacity, equipment availability and functionality, workforce distribution, geographic access gaps, identify bottlenecks in the diagnostics to treat pathway. Step number 2, which is policy and financing agreement, update national policies to reflect the WHA 78 commitment, secure sustainable financing, domestic budget, development partners, and strategic public-private partnerships. Integrated service design, co-plan imaging and radiotherapy expansion, ensure imaging availability at every radiotherapy site, formalize referral and feedback loops between radiologists and radiation oncologists. Digital and AI enablement, deploy teleradiology to underserved region. And I think this is one of the main pillars that is really that we as Egypt highlighted and started working on. Introduce AI tools with caution, with clear governance, workforce training, ethical and regulatory oversights. And this is something that is of extreme importance because as we all know, and as our distinguished speaker before me, AI is coming under any circumstance, whether we like it or not. So it has to be properly governed or we're gonna lose control. Monitoring, evaluation, and trust building. Track indicators like time to diagnosis, time to treatment, treatment accuracy, and safety. Communicate transparently with patients and the public. Now the Egyptian experience, a quick brief on the Egyptian experience. These are numbers from 2020, where the total population at that time was 102 million. When we had a number of new cases on 134,000, deaths was almost 90,000 from cancer, and prevalent cases 278,000. These are the recorded numbers in 2022 and 2025 and expected numbers of new cases in 2030. As you all see, it is 235,000 cases that are new that are expected to be present in 2030, by 2030. What did the Ministry of Health do? The GDR is the General Department of Radiology, which I am supervising. What's its strategic goal? Expand access to essential imaging services, prioritize basic modalities, mobile radiology units. We started in 2022 implementing mobile radiology units in order to be able to go to remote areas, whether for screening or to do supportive imaging in order not for patients to move or to be transferred. And we started public-private partnerships in oncology, and we had our first triple P collaboration with Gustave Roussy in Egypt. invest in infrastructure and equipment modernization, upgrade outdated equipment. And this is also a sector that we started in the radiology and also partly oncology, is that we don't just always buy new machines, but we update our currents, because the IB, which is the install base, is very big all over Egypt. So you cannot cover the expense of all the new machines. So you can just upgrade what's needed. Centralized procurement. This is very important to have the proper choosing of the proper specifications of the machines that you want to implement. Tiered service model, localized production, manufacturing. And this is one of the real arms that we did in Egypt, that we started local production. We partnered with our fellow companies, and now we're locally producing ultrasound, locally producing X-ray, locally producing MRI, and we're working on the next level that we're locally producing high-end CT. We're going to reproduce even contrast media. Strengthen human resources and training, expand radiologist training, subspecialty training, which is of extreme importance, task shifting, and retention incentives. These are urban hospitals in underserved areas in Egypt, where we just installed new machines like a cath lab, like a CT, and MRI. This is an image of our MRI units. We have 4 more CT mobile units that are going around all over the country, and we have 4 CT units and 1 MRI unit, which started working in 2022. And also we leverage teleradiology and digital health, national teleradiology network. We have a PACS system, an AI-assisted diagnostic tool, standardized quality and safety. We have national imaging guidelines, accreditation and audits, radiation safety programs, data research and monitoring, national imaging registry, support local research, and monitoring evaluation framework. And we launched our teleradiology program because Egypt, we have many hospitals in underserved areas, in urban areas that have lack of radiologists. So we are connecting to the data center 200 hospitals, and we're writing reports for 32 hospitals, and we have 52 radiologists on board working in these 32 hospitals since we started in 2022, and since we implemented our national VNA. And also we have diversity in use of PACS system. We don't have a single PACS system. We have 6 PACS system companies that we are working on with. We have also a very strong quality assurance department. We fully examined governance 9, and now we're going for 4 and 4. We also have an AI department, which just was launched in 2023. We're partnering with AI companies, and we're working on generating our own AI. And also the head of the AI department is Dr. Ala. She's with me here in Dubai, and we're happy to be here. We have 5 consultants and 15 volunteers who are working with us in the AI department. Just brief, this is my last slide. We have a 5-year plan, because no success happens without putting a clear plan to reach it. By the end of 2023, we will try to 100% fill our gaps, but we are working more to have almost 70 to 80% of all radiology services to be locally produced in Egypt for availability of the service and the machines. And this is our main target in Egypt. Thank you all very much.
That was truly superb, how you can implement. Mark, can you come? Our next presenter is Mr. Mark Stoesz. He's President, Enterprise Solutions, International GE Healthcare, and truly ambassador for global health. Mark.
Thank you, Professor Hedvig, and great to be here with you all this morning. So how does industry get involved, and what can we do differently versus what many of us have experienced in the past, which is effectively just buying a piece of equipment, installing it, and then paying over time, hoping that it stays operational for the next 10, 15 years. And that's really been the way in which in the past we've been operating. What are we doing differently now? Well, I would start by looking at focusing more on integrated partnerships with, whether that's a Ministry of Health or local advanced customers, luminaries to understand where we need to drive the business to be more successful, not for the business, but for the population of the people that we support. We heard some great discussions about education and training. We see a lot of impact that we need to do from that standpoint. So when we look at how GE Healthcare is looking at LMICs, and I think a lot of other OEMs are doing the same aspect, which is shifting from transactional way of working, moving towards longer term agreements and looking at procurement models that are not the standard, operating, capital expenditure models, but moving into different types of models from a procurement standpoint. And things that I think are really differentiating is starting to move into how do we support education and training as a partner. And as a partner, what I'm thinking about here, and I'll share some examples, is how do we work on building things like innovation hubs in underserved areas. The example I'll give is in Indonesia, where we've developed the innovation hub where we do education and training in collaboration with societies, in collaboration with luminaries, to make sure that we can build up this strength. So I was very excited to hear this morning from Professor Will about the work that is happening in oncology. From our side, we look more towards diagnostic imaging and what we can actually do to strengthen that and going forward. Additionally, it's around the digital tools. How do we develop tools that simplify the way of working? Of course, we have an prepared staffing availability of people, but how can we actually leverage AI tools and other tools to simplify the way of working together? And ultimately, this is going to lead us to a positive outcome. So this first example on the left is actually a video showing an AI tool for ultrasound. Why is this important? Well, if I take Dr. Fawzi's environment in Egypt, where they've done a very fantastic work in breast cancer earlier detection, where they've reduced just by clinical examinations, reduced by 80% the detection of advanced, or say more advanced cases of disease, stage 3 and stage 4 disease, we've now taken 80% of that out. Why that is important is, what do we do for the next step? So phase 2 of this project is to look at how can we use ultrasound, put it in the hands of non-expert users by leveraging tools like AI. And the example here is an AI tool from another vendor that is one that we're working with Dr. Fawzi and his team to understand whether or not by utilizing this, can we actually downstage even further to be able to address this specific disease. The middle two images, or on the middle and the right side of your screen, are examples of tools that we're looking at in the oncology space. How do we leverage AI tools, make it more use of agentic AI, large language models to assist the oncologist and in your treatment to understand what was the last radiology examination, what was the last blood sample that patient had, and put it into a longitudinal way so that it simplifies. Instead of going and hunting for the last examinations, it automatically pulls this and puts it into a longitudinal space so that it simplifies the way in which you as physicians and therapists can actually understand that data and bring it to life. And this is helping to reduce the overall complexity and operations in your communities if we implement these types of tools. So our goal is in GE Healthcare is to understand how can we deploy this in markets that are underserved and develop these tools. And for doing that, we do need to move away from the standard models of procurement. We need to start to look at it differently. So yes, we can still offer conventional procurement models where we just sell a piece of equipment, but more and more what we see and what we've experienced in these communities is a different desire. The desire has to be around how do you create a true partnership, whether that's a public-private partnership, whether that's through an NGO, whether that's through a government. How do we build this in a smarter way to create this solution that is really around whether that's a managed equipment where we take care of that equipment and keep it up to date over a 20, 30-year period of time, whether we look at a unitary payment approach where you pay one payment that covers all activities around that system and includes other aspects around training. So for treatment for the operators of these equipments, how do we improve that from bringing experience in leadership trainings. How do we look at change management? In some cases, there's a big change that has to happen when we look at bringing new technology into these markets and making sure the efficiency and utilization of that tool is brought to the state-of-the-art way of working. So from the standpoint of what we're looking at doing with respect to support of the community, it's really around bringing together different procurement models that are different than today's standard way of working, bringing into that education and training, looking at that from multiple different fronts, and then also on top of that, looking at how can we as industry support more the education across these parts of the markets that are underserved. So with that, I think I'll hand back to Hedvig, and thank you.
Thank you, Mark. Really, thank you. So, Saiful, I know we are running late. I'm sorry. I thought there were great presentations from the policy-making, government, industry, and then academia. And are there any questions for the audience, from the audience, for any of the speakers? Do you see any? I don't see. We are blinded here. Yeah. Okay. There will be time during the coffee time. Perfect. Absolutely. Yes. Thank you all very much. Thank you.
You don't have any slides for this? I have slides. Which one? Yeah. This one? Where is it? Industry. Yeah. One just in case. Yeah, take that out. And then, do you want presenter view or hide? Presenter view is fine. Fine. Okay. So good morning, everyone. Slide is, blinding. Yeah. If I may have your attention, please. Good morning. Good morning. Okay. So it's not every day that. So if I may have your attention, please. Good morning, everyone. Good morning. Yes, that's what I'd like to hear. Okay. So it's not every day that we are able to pull together the decision makers of the technologies that we use in radiation oncology, in imaging, and in AI. We're actually very fortunate to have those decision makers today on this stage together. The president of Varian Oncology Solution, the CEO of IBA, the executive chairman of Leo Cancer Care, CEO of United Imaging, and founder and CEO of Envision. They're all together. We're very fortunate to have them. And if I may request all of you to please come to the stage, and let's give them a round of applause. I know how challenging it is to get time from all these chiefs, the leaders from all the C-suite level, and really appreciate all of you taking your, valuable time, from your busy day to come to this launching ceremony of the meeting of AMSTRO. Thank you very much, for doing that. Really appreciate that. During the last year, there was a series of papers published in Lancet on cancer control in the Middle East, and it identified the various the gaps in cancer care. And those are the things that we have been talking about at this meeting. the lack of access to care, equity, financial sustainability, workforce development, and all of that. And there were also the call to action to the industry leaders to co-own some of these responsibilities to bridge that gap. So I'm going to ask a few questions to these our leaders here, based upon what we saw in that Lancet Commission report. And then before you know it, 30 minutes will be over. Since you have only 30 minutes, the way I would request each of you is the following. We'll follow some ground rules, and I'll put a question that I will ask each of you to respond to. And then when you do that, please introduce yourself, who you are and what your role is in your organization. And then I'll ask each of you a question, maybe a follow-up. And at the end, there'll be another question I'll ask. And before you know it, the time will be up. Okay. So with that, let me pull the first question in there. We know how to do a lot of things, but if you're new, how to, forward the slides. I'm a Mac person, so I get lost when it's not a Mac. Thank you. Thank you for saving. Okay. So this is a common question. Again, these are all based from the Lancet Oncology series. What is one real problem that keeps patients in this region from getting cancer technology? And what will your company do to reduce that problem by 2030? And how do you show that you have made progress? I see, as I go around, I see Dr. Rock Mackey. You are first, then I'll come around in the counterclockwise direction.
So you're starting with the youngest one first, I understand. So I mean, there's several problems.
Maybe you could identify yourself as who you are.
Sure. Rock Mackey. I'm a serial entrepreneur, former professor at the University of Wisconsin, responsible for Pinnacle at one point in time. Tomotherapy and Leo Cancer Care is a company that is developing upright radiation therapy, mainly for radiation therapy, but we see applications also in radiology. For CT scanners, for example, to be in the upright position, such that patients can be in the upright position. So I think the real problems are cost and access, and staffing are the two biggest problems. So if you talk about cost, for example, in particle therapy, it's sort of a good analogy between keeping pets and deciding what pet you're going to have. So a dog you can keep in your house, but a horse has to be kept in a stable. And if you want more than one horse, it has to be kept in a barn. So if you can reduce your expectations of what your pet has to be, you can reduce the costs. You can also make it easier for staff to do the radiation therapy by having systems that are really designed to be simpler. So upright radiation therapy, for example, is easier to set up. You can put these machines into photon vaults, particle therapy into photon vaults, protons, for example. We partner with Mevion to do that, or to put the systems into gantry vaults that already exist. And what that does is reduce the construction costs enormously by about a factor of 2. And so what this means then, it gives more access to radiotherapy. And in terms of CT scanning, we do conventional chest x-rays in the upright position. Why aren't CT scanners for low-dose lung cancer screening in the upright position? It makes a lot more sense because the lung is larger, it's easier to see lesions at less dose. Anyway, those are the two main reasons.
Thank you very much. And I'd ask each of you maybe to keep it within 2 minutes for every question. That we will be able to get to the end of all our session. Sasha?
Thank you, Saiful. Sasha Murik, I'm responsible for radiation oncology solutions for ovarian, Siemens Healthineers. I'm a medical physicist by training, spent about 25 years in a clinical setting. And, Seinfeld, where it comes to the global radiotherapy access problem, there was even a Lancet Oncology article back in 2015. And in no small part, what we are doing as ovarian is really going by that, knowing that people are definitely in a deficiency. The original Lancet article said that we would need roughly 2 times the number of LINACs by 2035, but that we would need 4 times as many practitioners. So, often I say, don't tell me what you're going to do, tell me what you've done. So we've taken the original 2015 Lancet Oncology and developed Halcyon. If you look at Halcyon, develops and installs in a really short amount of time. We've had a customer who's treated 5,000 patients in first 3 years of operation in Halcyon. That was in China. Another customer that's treated 250 patients a day, but all at the highest level, IMRT, IGRT. And I really think that in no small part, Halcyon has leveled the playing field for radiotherapy, where for the first time in the history of radiotherapy, as far as I know, there's a system that can be found in some of the most economically and logistically challenging parts of the world and at the leading cancer centers around the globe. So what you've seen from us with Halcyon, high throughput, high efficiency, ultra high quality at reduced power consumption sightings, we will continue doing that, not only for 2030, we know that the problem continues beyond 2030. So hopefully that was 2 minutes.
Oh, thank you very much.
I'm Al Zhang from United Imaging. And the United Imaging, we do imaging equipment, solutions, and together with radiation therapy. So I think the real problem, I agree with 2 colleagues before me, accessibility in this region is a real problem. And the accessibility actually means, first of all, there's a lack of equipment, radiation therapy equipment, PET. Now we have this diagnostics for cancer treatment. Then this lack of equipment, even we do have some equipment in some countries, and then a lack of expertise, professionals. So for these problems, actually, we're lucky. We started this company in China. The economic diversity in China, caused a lot of problems. Also, similar problems here, like healthcare problems in this region. So we see a lot of hospitals in Shanghai, Beijing. They have equipment, but they don't have enough also like high level good medical physicists, radiation therapy professionals. But also in the meantime, a lot of places in China, while West, they don't even have equipment. So I think then the solution for us, we try to combine, this medical imaging equipment and the radiation therapy equipment together using AI. So I think to solve this issue, we can elaborate more on this. One is that we need to have innovative equipment, and we need to use AI. And in the meantime, we have to set up, establish local training systems here. We need to train people here. We need to educate people here, and we need to have local service teams here. Set up the warehouse, like spare parts. We cannot let the systems sold to one country, then they broke, you cannot pay them. They said, I went to some African countries, the radiation therapy systems there, they can be broken for years, for a year or 2. They're just not repaired. So we need to have a good partnership and the ecosystem here to make sure, the people have good equipment. In the meantime, they have education training. We need to provide this. We need to work with our local partners to do that. And also make sure AI can be used. So we have a good, we call it CT LINAC. We integrated diagnostic CT into the radiation LINAC system, right? The same gantry. We have 2 systems. And then we use, when the patient lie on the same table, get CT scan and move to the LINAC system, the AI already generate this treatment plan within a second. So the patient doesn't need to leave, and you don't need you don't really need a medical physicist there. So now we have tried that. We installed one system in Peking Union, which is the best hospital in China, and then one system in Tokto, the county hospital in Mongolia, which is like 500 kilometers away from Beijing, and that hospital doesn't have a medical physicist. So like the technicians put the patient on the table, then get the CT scan, and when the patient moved to the same table, moved to the LINAC, the treatment planning is generated and sent to the Peking Union in no time, right? So Peking Union doctors there, they do quality control. They start the treatment in Tokto County Hospital, which doesn't have a medical physicist. Then they can do the treatment within 20, 30 minutes. So by doing that, I hope we can replicate this in these regions. And of course, we still need to train. We start up the training system, education system together with our partners here.
Thank you.
Thanks.
Thank you. Mahmoud?
Hi, I'm Mahmoud Hassan, founder and CEO of Envision AI. Envision AI building AI systems for last 8 years. The company is based in Helsinki. It's one of the region where a lot of the treatment planning system comes. So Envision develops cloud scale AI solution for radiotherapy clinical decision support. In our last 8 years of experience, where we're scaling our AI solutions to right now in 25 different countries, 3 major problems that we see. One is, of course, everybody agrees that the lack of staffing and quality of their training. Second is poor IT infrastructure, basically not having access to cloud and those kind of GPU infrastructure is a problem. And the third thing is poorly understood the law of patient privacy and data privacy law. But many countries actually taken very active measure on that. For example, in UK, almost 25% of all radiotherapy patients are controlled by Envision AI systems. And so UK and the NHS system has been pioneer in terms of developing a very comprehensive IT policy, the patient privacy, and the infrastructure that they built. Also a very rigorous training system as well. The solution is how we can learn from some of the learning from many different countries are doing this, and how we can replicate into this region would be the right way to go about it.
Thank you.
Good morning, everybody. I'm Olivier Legrain, the CEO of IBA. IBA is the leader in proton therapy globally and in nuclear medicine. IBA is enabling innovative radioisotope for diagnostic, which is very important, as we have already mentioned in an earlier presentation. But more and more, nuclear medicine will play a role in what we call radioligand therapy, which is a way to attack systemic disease. So what about the region? I think one thing that we don't talk about enough, in my eyes, is that radiation therapy is a super cost-effective way to treat cancer. Do you know that radiation therapy treats 50% of the cancer in developed countries for only 5% of the cost spent in oncology? So that's something I believe that as an industry, we need to shout more. When it comes to proton therapy, we believe today IBA is delivering the lowest cost per treatment. And one of our commitments is to continue to work on that. And the way to do it is to treat more patients per system. So we are investing a lot in uptime, but also in innovative way to deliver proton therapy, such as dynamic arc and flash hypofractionation. The latest has been touched upon already, which is training. And IBA has, over the year, developed a fantastic install base with a lot of luminaries. And what we want to do is to take all the knowledge and make it available to the region. So development of proton therapy can be very quick, and the ramp up can be quick. So very quickly you can treat more patients. And that's our commitment.
Thank you. Thank you very much. It seems that cost per treatment is a consistent theme, as I hear from all of you, and innovative ways to reduce that. Let's go to the next
question, and I'll ask Dr. Sasha Mutik. So what is Varian's public pledge for installation to first patient for new linear accelerator installations in EMRO and Asian low and middle income settings by 2027? And will you commit to a target of 90 days or less?
So Saiful, easy to commit because I believe we're already there. So if you look at Halcyon, the system roughly installs in 1 to 2 weeks, and it comes pre-modeled, pre-commissioned. We also have advanced oncology solutions that come on site and can help with the commissioning. So from the perspective of system being installed and going live, we routinely see 2 to 3 weeks timeframe. It can actually be done faster. We don't encourage it because we need training. We need to get the site ready. And then from the perspective of the ramp up time, we see routinely customers ramping up 20, 30, 40 patients within a month. What's interesting is we also see similar with ETOS, our adaptive system, that installs quite fast. And then from the very first day, customers will do online adaptive treatments. So this is not that difficult. It's already there. I think the harder part is really for all of us as a society to realize what is possible, because these questions come up still often. We don't have a way how to easily distribute best practices. So I think the conference like this is super, super important. So what I would say is where our commitment is, we will continue doing this at a large scale, highest quality, highest safety, but also to partner with you and AMSTRO on how do we educate customers and clinicians around the world of what is possible, and then what are the best practices.
Thank you. I'll make it harder for you. Maybe 60 days or 30 days.
I believe we're there. So
okay, all right. You know the bit, right? So we will come back. We'll listen to you and find out that is that really what's happening. That's the idea of this, so that we can hear from the decision makers, what they decide, what they're committing really. They're making a pledge here, what is possible. And we'll follow up with you before the next AMSTRO meeting. So maybe a follow-up question, Sasha, is that what concrete changes, for example, accelerated service models, remote commissioning, standardized beam data libraries, pre-configured training bundles, or regional service hubs that Varian will implement to actually deliver that pledge, which you are already within weeks, you said, right? So
yeah, so several again, our machines do come with the pre-modeled data. We have advanced oncology solutions who will come on site, collect the data, commission, and set up the clinical procedures. They will also come with predetermined clinical protocols and applications for go live. From the perspective of regional service hubs, we have been in Dubai directly present for well over a decade. We service fairly large area out of Dubai directly. And again, even from the perspective of service models, uptime, all of that, super proud that we have, I think, somewhere over 10,000 Linux in the field, and our average uptime is in 99% range, and it is globally. Every now and then, we have a problem with the system here and there, but on average, really, really high. So again, I would really kind of challenge all of us to really realize what are the best practices and how do we drive them. My sense is that technology often is ahead of just us being able to be there. So this is where the conferences like this super, super important. But we will continue also standardizing on a beam model, standardizing on machine QA, automation of QA, things like that. And that I think that there's an infinite appetite. The QA does end up being one of the greatest bottlenecks to technology adoption. So the faster you can make it, the easier you can make it. I don't think that you can ever overdo that. So that element is there. But again, with our clinical service team, which is now global, scaling rapidly, I believe we can service the needs and really just need opportunity like this to educate our customers.
Thank you. It's combined with that also the time that the medical physicists have to spend once you have the BIM model coming from the factory. right? But the roles of the medical physicists are also to check, so those are all get into, yeah. So thank you. Thank you very much. Let me go to Mr. Olivier Legrain, the CEO of IBA. You have a new, the proton machine that is coming to Dubai, right? So this is exciting, a new technology coming in this region. So my question to you is, how do you ensure proton therapy in the AMSTRO region becomes a regional access asset rather than a boutique technology limited to just a small number of patients who can afford it?
Well, I think indeed the first thing is to make the technology available. So we're super happy that YAS has decided to partner with us to bring proton therapy to Dubai, to the Emirates. I have to say globally, if I look at the AMSTRO region, actually IBA has been present over the years. And if I take the example of India, I think we have shown that despite the fact that proton therapy is perceived as an expensive technology, we were able to bring it very successfully, both to the public and the private in India. And more to come. Actually, you have seen that more Indian institutions have decided to go for it. So I believe that if we can show that it's not as complex as it looks like, that partnering with IBA makes it, a kind of seamless project from the start to first patient and thereafter, including uptime, as Sasha has mentioned. So continue to deliver the value of proton therapy by continuing to deliver projects by the book, by continuing to innovate so we can treat more patients, decrease the cost per patient, and make it available to more patients so people will understand